Okay, good afternoon, everyone. Welcome to this SOM webinar on burnout in healthcare risk factors and solutions. Very timely. I think we're all feeling a bit burnt out, need a holiday, but more seriously in healthcare, this is a real problem. And at the new NHS workforce plan, which came out recently, it's got some pretty ambitious targets for people they need to retain, reduce the leaver rates from 9.1% to 7.4 to 8.2% over the next 15 years. So a real challenge for the healthcare in this country to ensure this happens. SOM's really, really grateful that Professor Gail Kinman and team have produced this report. It's really excellent report, and you can see the link in the chat. It covers approaches to it, risk factors and solutions. Sometimes there's all kinds of approaches that don't work. They're not evidence-based, and as the Society of Occupational Medicine, we are focused on evidence-based interventions that really work. We're also really appreciative of Gail. She covers lots of areas, across occupational medicine, from supporting the Journal of Occupational Medicine to chairing the occupational psychology group, and we've got Kevin Teoh, occupational psychologist, here on the panel too, Professor Anne Harris, past president. So we are hoping this report will be something you can use in your work. It's not just in healthcare, it's also useful for people working in all kinds of settings, from corporate, commercial, military. I'm sure Neil Greenberg, Professor Neil Greenberg, trustee of the SOM and chair for today, will also cover that. But do introduce yourself in the chat, put your questions there. There's time for that. Got some lovely time for any questions you may pose, so do get involved. But I'm going to pass over to Neil now, with my thanks to you and the team and everyone presenting for what is a great report. Thank you so much. It's really appreciated.
Hi, hello there. Thanks very much indeed, Nick, for that intro. My name is Neil Greenberg. I'm a consultant psychiatrist. I'm based at King's College London. As Nick said, I'm also a SOM trustee, which is a definite pleasurable part of my day-to-day job. And I'm going to chair today's session. Could I have the first slide, please? So great. And so this session is all about burnout in healthcare, which is the focus of the guide that has just come out. You can see there the authors and contributors, and it certainly is a really useful guide. And if organizations are able to put in practice all the stuff that's in there, and Gail's going to talk about that after me, then I'm confident, with an evidence-based hat on, that actually good things will follow. So the way we're going to run today is I'm going to speak for just a little bit. I'm going to hand over to Gail, and then once Gail's spoken, we're going to have a panel of 4 different topics with some of the contributors talking about them, and then there'll be some opportunities for questions. And so what I'd encourage you to do, and I can see some of you have already done that, which is great, is please put in your questions into the chat. You don't have to wait till the end of the talks or to the panel to do it. You can put questions in at any time. And then what I'll do at the end, once the panel's finished, is take those questions and sort of go through them. So if you put them in the chat, I promise I won't forget them. The next slide, please. So why is this topic important? Well, I mean, the NHS obviously had its birthday yesterday, which is great. And it's fair to say that as the birthday celebrations were happening and the media was covering that, most of the media stories included something about, has the NHS got long to live? Can it carry on in its same format? And these are, you can see here, are just some of the headlines that have come up over the last few months about healthcare staff, and you've got some going right back there to during the pandemic in 2021. And what seems to happen with the NHS is, whether this is true or not, is the media portrays this crisis after crisis happening, and that leads, unsurprisingly, to an impact on staff well-being. In my job at King's College London, I'm one of the chief investigators on a study called NHS Check, That has around 23,000 NHS staff in it across 18 NHS trusts in England. That study's been collecting data since April 2020. So we started during the pandemic, but we've carried on collecting data since then. And the stories that come out in the media about the mental health crisis and the end of the world and doom and gloom, some of that is true. But when we carefully look at the real facts, the sort of 25–30% PTSD rates that some articles quote just aren't true. And so one of the important things when thinking about mental health in any organization, including the NHS, is to be really cautious about the figures that come out of self-report surveys. Now, those reports, the self-report tools are really useful. In clinical settings, they're excellent. But when you start handing them out to a group of people and you do a stress survey or something along those lines, you get these very large figures. And the context of the data gathering is as important as the data itself. So yes, we should be worried, but as you can see here, if you've got 58% reporting mental health problems, 93% reporting stress, when you actually cut it down and you do careful interview-based studies, just talking about PTSD, post-traumatic stress disorder, for instance, we find that actually the real rate's about 8%. Now, that's still double the rates you would find in the general population. So that is absolutely an important figure, the 8%, but it's not at the level where the media would have you believe the end of the world and implosion is nigh. And I think it's important that we keep in our heads.
So Donna, just, well, yourself. So just keep with,
I'm sorry, someone's put themselves, thank you, sorry. Someone, if we can keep ourselves on mute, unless you're speaking, that would be really helpful. Next slide, please. So I just wanted to just to say, we should absolutely think about the mental health of NHS staff, and burnout is certainly part of that. But what we must not do is to be persuaded by the media that this is the end of the world. Now, this is just one last topic I want to cover very briefly before handing over to Gail, which is the topic of moral injury. Now, moral injury describes the very strong emotions we get when we're put in a situation which just shouldn't happen. So it's where it breaches or it clashes with our moral or ethical code. And there's been lots done recently about moral injury in healthcare workers. And I wanted to put this slide up because there are 3 different ways that you can experience moral injury: acts of commission by others or by yourself, but also betrayal. And you can see here that actually betrayal, feeling betrayed by my manager, by the organization, by the executives, by the government, by the nation, actually betrayal comes out very strongly as the strongest cause of moral injury. And also you can see that is linked with burnout as well. And so one of the underlying themes here is that we need to support NHS staff better, because actually otherwise they become morally injured, they become burnt out, and they become unwell. And the key thing here for patient care is that we know, of course, that any member of staff whose mental health has been affected actually has the potential not to necessarily deliver the best care. And I'll just leave you on one slightly dismal point before handing over to Gail, which is that I don't know if you've heard of NHS Resolution, which is the NHS's litigation authority. They pay out £2.6 billion per year. Most of that goes to patients who have unfortunately been wronged, have been harmed in some way. And so I don't know the exact numbers because no one has done the studies, but I am very confident that some of the reasons why that harm occurs are because the staff who are doing the work probably have some mental health difficulties. So if we could even make a 10% difference, that would be a £260 million saving. So actually investing in healthcare staff mental health actually will really have some huge dividends for patient care, and also for the amount of money that the NHS has to spend on looking after people and doing their job. Right, so on that point, I will ask for the next slide, please, and I'll hand over to Gail, who has definitely been the powerhouse of this, the guide. Professor Gail Kinman, as you probably know or you don't know, is an occupational health psychologist. She's very widely published on lots and lots of topics relating to organisational mental health. She's a fellow of the British Psychological Society and the Academy of Social Sciences, and she has a long-standing interest in work-life balance, which hopefully she does herself, as well as doing lots of presentations. But I'll say thanks very much, and I'll hand over to you, Gail. The floor is yours.
Thank you very much, Neil. Really compelling arguments, I think, here for understanding burnout and obviously putting interventions in place. Now, before I start, I would like to acknowledge the contributions, the very valued contributions of the co-authors and also the people that contributed the case studies, but we'll be talking a bit more about that later. Okay, so, delighted today to launch this guide. It's been a while coming. Quite a lot of effort, as you can imagine, has gone into writing it and reviewing it too. So just to give you some kind of idea of the things that we're covering in this guide. Now, it was designed specifically for occupational health professionals and associated roles in healthcare. But obviously, we know that it's relevant to occupational health psychologists and also the growing number of people who are responsible for managing well-being in organizations and also in other sectors. So, we would encourage people to use it because it was written to be used. The guide provides a general overview of the nature, causes and signs of burnout. Now, there's a vast literature on burnout, so we've done our best to try to synthesize this literature and make it fairly straightforward and easy to understand and use. The guide identifies the prevalence of burnout in healthcare and also the key risk factors. We know that healthcare workers are at high risk. So we also need to understand the key risk factors, whether they're occupational, organizational or individual, in order to put targeted interventions in place. It also highlights the implications of burnout for well-being and performance. And, we will see the wide-ranging costs for workers, organizations, and also patients. Very compelling argument to take action. It importantly provides examples of multi-level strategies, so strategies at the organizational, the individual, and the tertiary level to manage burnout. And finally, it includes case studies to illustrate the key issues arising. And the people who contributed these case studies will be on the panel afterwards to talk about these key issues and also will be available to answer questions. So just moving on now. Now, what is burnout? It's been defined in lots of ways, but I think a generally agreed definition is this state of physical and emotional exhaustion. Now, it's not because of life in general. It's to do with excessive and prolonged interpersonal work-related stresses. And I would like to add there that these stresses need to be largely unmanaged. So, it isn't something that occurs overnight. It's something that unravels over time, if you like. It's important also to emphasize that burnout is not a medical condition nor an illness. It's a syndrome. It's recognized by the World Health Organization as a syndrome resulting from chronic unmanaged workplace stress. Now, it isn't the same as just being very stressed. Obviously, is a bit of a buzzword at the moment, but there are very many differences, as we will see later. Now, we know that people working in many different types of job can be at risk of burnout, but it is a particular risk for people working in the so-called human services or in the growing number of people working in caring roles. Now, these are roles that are emotionally demanding. Just to move on. So Maslach's early work with helping professionals documented this process really by which burnout can occur. Now, first of all, you have people who are doing emotionally demanding jobs that involve sustained compassion, sustained care. And there is a risk of emotional exhaustion where people feel overextended. They feel their energy, their mental and physical energy is drained. So in other words, they feel emotionally depleted. So in order to as a form of self-protection, if you like, or a coping strategy, people may put up these emotional barriers. And as Christina Maslach herself said, you know, it can be a bit like a suit of armor to protect you against, you know, the potentially damaging effects of being overly emotionally exhausted. So depersonalization and cynicism is the second aspect of burnout. And this is an active disengagement from the job that can lead to negative attitudes towards other people, including patients and colleagues for healthcare workers. And obviously that can be a problem because many people go into this job because they really want to make a difference. And they really feel the need to forge very close emotional connections with others. So that can lead to a reduced sense of professional efficacy, which involves a poor sense of achievement, loss of sense of purpose, and also meaning that they get nothing out of the job role. And this obviously, you know, is not necessarily a linear process, but I'm just giving you an example of how this process may occur. So what are the signs? Now, burnout can manifest itself in very many different ways. And we can see here that there could be 5 sets of changes. First of all, we can have emotional changes where people may feel angry, they may feel frustrated. Commonly, they may feel anxious, fearful, and panicked. And many people describe feeling paralyzed, where, you know, they're unable to make even the most simple decision or make any changes in their life. So these feelings have been overwhelmed and trapped. Very commonly also, people may feel a sense of emotional numbness or blunting, where rather than, you know, we're normally a bit up and down in terms of our emotions, but, you know, people tend to be often emotionally flat. Cognitive changes also are a key issue, which can be a particular problem in complex work, where you may have problems with concentration, memory, thought processes, creativity. You may procrastinate about making, as I said, even the most simple decision, and that may become very, very stressful for you. This increased cynicism, which I mentioned earlier, can also manifest itself as suspicion of other people and their motives. Rumination also over minor offences, you know, where somebody does something which really isn't particularly important, but, you know, you will worry and ruminate away at it. And also doubts about your particular competence. Physical changes can occur with burnout as well. Insomnia is particularly common, where people are unable to fall asleep at night or continually wake up, which can obviously lead to chronic fatigue. Mentally unexplained symptoms can often occur in terms of, you know, digestive problems, headaches, etc. And also the dysregulated immune system that can be related to long-term chronic stress and burnout can lead to increased vulnerability to infectious disease. And of course, you know, if you are working in a healthcare environment, you may be more likely to be exposed to that. Social changes also. Now, often people feel alienated from others, but they tend to withdraw socially as well, which can lead to a sense of isolation and this sense of not being understood, being alone in the world. And finally, behavioural changes, again, very common. Irritability, again, that can alienate potential sources of support, you know, by sort of this irritability and anger. Lack of empathy and compassion for other people. Poor self-care. And I think with poor self-care, often comes self-medication through, you know, food, through alcohol, etc., or drugs, where people are trying to cope by using substances. And people also often feel that one of the first signs actually of burnout can be this lost sense of humor. But I think, you know, one thing that I do want to emphasize here is that research does emphasize that there can be a lack of awareness about signs and symptoms in healthcare professionals. And they may be feeling and experiencing these things, but, you know, they don't necessarily know that these are signs of burnout. And this can be a particular problem in early career professionals. So obviously, you know, we do need to communicate these issues. Sorry, I seem to have move the slides. Okay, so what about the extent of burnout in healthcare? Now, obviously, as Neil said, we do need to be very careful about self-report, particularly using questionnaires. And as we have already seen, we know that healthcare workers are particularly vulnerable to burnout. And we know also that many studies showed that the risks increased during the pandemic. Longitudinal studies tracked people's burnout scores over the pandemic. Now, the NHS staff survey, the annual survey, in 2022, 636,000, wow, people working across 215 trusts completed a range of measures, including questions about burnout. Now, these were taken from something called the Copenhagen Burnout Inventory that doesn't look at burnout as the three separate components, but gives you an overall score. So I just wanted to give you just a general idea of the percentage of people that answered often or always to some of these questions. So as we can see, 46.3% indicated that they felt worn out at the end of their working day. 39.9% reported their work frustrated them often or always. Over a third find their work emotionally frustrated. A similar proportion feel burned out also because of their work. Evidence that this burnout can impact on work-life balance because nearly 32% reported that they don't have enough energy for family and friends. So basically, you finish your shift and you just want to lie down on the sofa or go to bed. 30.8% feel exhausted at the thought of another day shift at work. So this sense of feeling defeated by the emotional and physical demands of the job. Now, the NHS staff survey do provide an overall score, as we can see there, but they do break it down by job role to some degree. But I'm just going to be moving on now to give you some more specific findings in terms of the extent of the three components of burnout that have been found in particular studies. Now, obviously, we do have to say, and I think this draws on and reflects some of the points that Neil made, is that you tend, if you review studies of burnout in any particular population, you tend to find that the proportions differ. Now, this is because different measures tend to be used and also different cutoff points. So, that's one of the reasons why the proportions of people are found to be, reporting burnout tends to vary. Now, first of all, looking at studies of physicians, narrative and systematic reviews conducted by myself, Kevin Teoh, and Anne Harris suggest that, the levels of emotional exhaustion, depersonalization, and lack of personal accomplishment are actually fairly high. So up to 72% signs of emotional exhaustion, 68% depersonalization, and 63% lack of personal accomplishment. But again, obviously, we do have to emphasize the nature of the measures. Certainly, the reviews that we've conducted and other people have conducted find, has somebody got their mic on?
Yeah.
GPs in critical care tend to be at higher risk, and I think of considerable concern is a recent CMC survey that suggests that trainees are at an increasing risk. Now, it used to be thought that burnout is something that occurs gradually over time. So people start in their career going to be really at very low risk. But certainly this research suggests that, there are worryingly high levels even at very early stages in the job. So 63% of these trainees were showing signs of burnout in the 2022 survey. Nurses and midwives, now again, reviews that we and other people have conducted find up to 51% are showing signs of emotional exhaustion. Now, most of these studies find that emotional exhaustion is more common than the other components, but 32% depersonalization and 30% lack of personal accomplishment. And breaking down the NHS survey results for nurses only suggests that 39.7% reported often or always. Now, in this section, I've included nurses and midwives, but midwives are not often looked at. And I think that is something perhaps that we need to consider for future research. And certainly there is some evidence that critical care nurses are at higher risk than other types of specialisation. Some research on ambulance operational roles. Now, the NHS survey found that 49.3% of people doing operational roles in the ambulance service reported burnout often or always. And another study highlighted more than half of their sample reported burnout and 87% depersonalisation, finding that lone responders are at higher risk. Now, that really does tend to pinpoint, doesn't it, the importance perhaps of targeting lone responders and perhaps giving them more support. But I think, something that I do really want to emphasise here, and this can be seen as a paradox, in that many of these studies of healthcare workers also find high levels of satisfaction, engagement, passion for the job, and a sense of personal achievement alongside these high levels of stress and burnout. Now, this can be a problem, I think, over time, because sometimes a sense of engagement and passion for the job can keep you going, even though perhaps your physical and mental health may be suffering and you may be showing signs of burnout. So it's actually hard to step away, I think, for people who are burning out. Moving on now. Now, as I said earlier, it's really important to conceptualize burnout as a process rather than, an individual set of symptoms that a person may present with. So this is a typical trajectory that's been described in, let's just say, a particular healthcare worker. So first of all, we may start off with these high expectations and idealism. And I think one of the case studies in the guide illustrates this really, really well. So, high expectations, idealistic, really excited by the job, getting a lot out of it. Maybe a sense of disillusionment kicks in at a relatively early stage. So a sense of pessimism and perhaps dissatisfaction, early dissatisfaction with the job. In turn, if no intervention is put in place, this can lead to a sense of withdrawal and also isolation, and people moving away from the job emotionally, so disengaging themselves from the job. And finally, an irreversible sense of detachment and loss of interest at the job, and maybe some kinds of health breakdown. And, as I mentioned here, that at each of these points, it's really, really important, obviously, to have a detection. But, at the very early stages, it's really important to be able to pick up these signs and these symptoms. And I think this quote here that we included in the guide is particularly relevant by an endocrinologist. So what started out as an important, meaningful and challenging work becomes unpleasant, unfulfilling and meaningless. Energy turns into exhaustion, involvement turns into cynicism, and efficacy turns into ineffectiveness. And that can sum up the burnout process very well indeed. So what about the organizational risk factors? Now, we know that there are certain occupational risk factors for burnout in healthcare because, the job itself often involves requirements for sustained care and compassion, and that can lead to emotional labor, which can lead to emotional exhaustion and emotional depletion. But, what we do know from the evidence is that it's the organizational risk factors that are most important for burnout. They are the most common causes of burnout. So it's not the job itself, it's a range of issues that have been identified to do with the organization. First of all, occupational cultures. Now, many people working in healthcare will say that, this environment can encourage self-sacrifice, where perhaps self-care, is seen as a little bit of a luxury and not as important as, delivering care and compassion. And indeed, some people have said that burnout can be seen as an inevitable cost of caring. Secondly, workload pressure, one of the most common causes, pressure of meeting targets, again, bureaucracy, administration, long hours, shift working, low staffing levels and lack of cover, really, really important cause of burnout, and, emotional depletion, and the ability to take few breaks. And certainly that has come out in quite a lot of studies that, healthcare professionals may be unable to take a break, and, may be unable to even go to the loo, have a sandwich, etc. Thirdly, lack of autonomy and input in decision making, lack of respect and appreciation, all really, really important factors for burnout. Role ambiguity, poor resources, and also poor relationships in the organization, but, bullying, culture, and aggression. Now, aggression can come from colleagues, it can come from managers, and it can come from patients. Poor leadership and management, again, a very common cause of burnout. Lack of support, poor communication, and I think this is something that resonates a lot in healthcare. Excessive and poorly managed change. So change, can be endemic. People working on conditions of job insecurity and precarious employment. Contract workers may be at greater risk of burnout, but we actually don't know very much about their situation, because they're much harder to get at than people with permanent contracts, in terms of perhaps studying them. And I think finally here, this links very much with what Neil said about the value conflicts that people can experience in healthcare, particularly coming out from the pandemic, the sense of moral injury, feelings of injustice and unfairness, this idea of a poor psychosocial safety climate as well, where there may be mission statements in terms of caring for employees' well-being and supporting that, but there's a perception that there is not necessarily a very deep commitment to addressing the causes of problems. Stigmatization of help seeking, and also barriers to seeking support. Now, the support that is available isn't always well signposted, and it may not necessarily be available at convenient times or in convenient places for people. So, these are the key organizational risk factors based on review of the literature. There's also a range of individual difference vulnerabilities here. Now, as we've seen earlier, job experience can be an issue, and there is evidence that the risk of burnout can actually reduce over time. But we do have to acknowledge something called the healthy worker effect. And what happens here is that people who are more badly affected by the job, who are unable to cope, who have a range of health problems, are the ones that leave. So what we are left with are the survivors. So, the survivor effects may mean that, they're better able to cope, and they're less vulnerable to burnout. So that may explain the risks for early career. Orientations towards the job and relationships in general. There's a number of individual difference factors here that are really interesting. Dysfunctional workaholism, people having few outside interests away from the job, over-involvement in the job, and another really interesting tendency is something called rescuing or white knight syndrome, where people feel this inner compulsion to rescue and help people. Personality and background, maladaptive perfectionism is a key, is a key issue. It's where it isn't necessarily a problem if you have high standards for yourself, but it's when you feel other people have high standards for you that you cannot necessarily achieve. Introversion, a passive coping style, poor emotional regulation skills, and also a past history of trauma. Then we have work-life balance issues. You know, there can be risks where people may have weak boundaries between work and personal life. They may ruminate excessively about problems and have difficulty switching off, which means they are unable to recoup their mental and physical resources. And finally, we have a range of demographic factors to do with being in a minoritized group. Now, that can be to do with ethnicity, but also to do with, and I think, an increasing recognition of the issues to do with neurodiversity. And Nina is going to be talking about that a bit later, because that is a key risk factor. Implications for patients. Now, you know, there are some studies, quite a few studies out there that are looking at staff burnout on the one hand and patient safety outcomes on the other. We know that there is some evidence for increased risk of decision-making, difficulties, error-making, etc., and some evidence that there may be a higher risk of mortality. Another risk for patients may be impaired teamwork, where people, you know, may have increasing conflict in the team. Their communication processes may be less effective also. And a sense of social withdrawal means that you're not necessarily a particularly good team worker. So that can be another issue. Interactions with patients. Now, there's something called compassion fatigue, which I'm sure you understand what that means. It's where, you know, a bit like emotional exhaustion, lack of engagement with patients, and also perhaps a sense of carelessness. There's also links found with patient satisfaction via depersonalization and cynicism, low motivation and energy, etc. And of course, we know that burnout is linked with turnover. We know that it's linked with absenteeism, but it's also strongly associated with presenteeism, where people continue to work while they're sick. And this can lead to error making, as well as in any safety critical type of job. But I do want to emphasize here that although there are risks for patients coming out in the literature, we do have to say that healthcare professionals really do make considerable efforts to ensure that patients don't suffer, and will put a huge amount of effort in there to maintain performance, which often means that they will work until crisis point is achieved, and they then have no choice but to step away. Okay, so moving on now to managing burnout in healthcare. Now, we advocate a multi-level approach. This is the most effective approach is to combine all three levels of intervention. Primary interventions, the most successful, and these tend to identify the risks for burnout at source. So they're interventions that will put something in place to actually identify the risks, implement and evaluate interventions, etc. Secondary interventions are those that attempt to improve people's ability to cope with, you know, what it can be a very challenging job. So, you know, we will talk about each of those in greater depth in a minute. These initiatives can be at the team level, but also at the individual level. And finally, last but not least, because I think this is a really key issue for occupational health, are the tertiary interventions. Now, these focus on people who already have problems with burnout, and they seek to rehabilitate people and adapt their working conditions, make reasonable adjustments to their needs and support them back to work. So first of all, what about primary interventions? Now, this is all about changing the organisation. So what can we do? Now, this is summarising a lot of information that is in the guide that really should be helpful for people to put actions in place. First of all, assessing your psychosocial safety climate, really important. And this is all about workers having a shared belief that their well-being is supported, and there is a deep commitment to doing this in the organisation. It's not just rhetoric, let's just say, you know, there is this deep commitment there. Assessing the risk factors to enable you to tackle them at source and prioritise, you know, tackling these risk factors. What can be very useful here is the Health and Safety Executive Management Standards approach. that benchmarks wellbeing across a range of key areas. But we also very strongly advocate the inclusion of job-specific hazards, because obviously in healthcare and even within healthcare, different roles do have their own specific hazards. So that's very important as well. There is increasing evidence of the importance of training line managers to support the well-being of their employees. But, I do have to say here that we also need to support the line managers too. So training line managers to identify burnout at an early stage, understanding the risk factors, increasing awareness of the resources also, and being able to signpost people to these resources. Taking a personalised approach also to managing well-being. Now we encourage the use of these wonderful wellness action plans that can be a very person-centred approach, increasing opportunities for autonomy and support from managers and colleagues also. I wanted to include this because I think this is a framework developed by Leiter and Maslach, who have done a huge amount of work on burnout. Now, they reckon that this framework is particularly appropriate to organisations like healthcare, that have sustained human interaction. So the idea is that we need to improve the fit between the person's needs and the job across these 6 different areas. I won't go back into them again because I think they're things that we've covered already. But, I think it's a really good way of ensuring that interventions are available to cover all of these issues, including recognition and reward, clear values and meaningful work, drawing on the risk of moral injury, etc., workload and support. So that can be very helpful. Secondary interventions. Now, these are all about helping people cope more effectively. And certainly my own work on self-care and people working in health and social care certainly recognises the need for people to have strategies to care for their physical well-being, their mental well-being and their social well-being. Building this supportive network is important, increasing team support, identifying what we call signs of struggle, which can differ. People don't always come out and say, I need help. They may show that they need help in different types of ways. Prioritizing self-care also, recognizing and avoiding dysfunctional perfectionism, promoting reflection, emotional literacy, really important too, protecting boundaries for work-life balance, prioritizing recovery, and enhancing e-resilience. Now, this is something that we've been working on that is really all about ensuring that people can engage with technology in a healthy and sustainable way, which is really, really important. So now some useful interventions that we advocate and I tend to use in my own work are things like Schwartz rounds, peer coaching, emotional writing or journaling, mindfulness, boundary management techniques. And there is some evidence that we found that digital interventions can be helpful, but they are very much of varied quality, so we do need to be very careful that they are evidence informed. Almost there now. Tertiary interventions. So again, we have a key role here for occupational health that Anne and Janet will be talking about a bit later. Now, this is all about, occupational health professionals can be really, really important key roles in the organisation in terms of informing strategy, communicating best practice on well-being and how to avoid burnout, monitoring well-being, etc., having these tools and measures in place, being aware of co-occurring illnesses. Now, I haven't mentioned that today, but there are a range of syndromes and illnesses, like depression, etc., that can often be mistaken for burnout. Identifying patterns in organisations as well, maybe in particular teams, in particular departments where, there is a high risk of burnout. Raising awareness of the signs and symptoms, identifying what managers need to know. Treatment. Now, some people may need this type of input, and Alan Dovey is going to be talking about that a bit later. So providing opportunities for coaching, CBT can be particularly helpful, you know, throughout the burnout trajectory, and psychotherapy if required. And I think last but not least is supporting people to return to work via this planning, having tools in place, and also monitoring people's progress over time. Kevin, I think, is going to be mentioning this a bit later, but this is something that we include towards the end of our guide. And again, this is a really nice framework that helps people target interventions at these different levels. And it's called the Igloo. And it's all about, you know, the context, the organization, the group, the leader, and the individual. So finally, to leave you with just a few key points, I think we need to see burnout as an organizational problem, absolutely not an individual problem. Provide information on the signs, view it as a developmental process that can intensify, identify the causes, take action at multiple levels, communicate the risks of overload, you know, that it is not sustainable over time, set reasonable expectations of employees, ensure people are assured of their value, to the organization, and also, you know, this can help moderate the impact of workload on well-being. Use recommended measures, try to avoid these, you know, these sort of varied measures and frameworks. There's a lot of really good ones out there that have a lot of evidence. Make sure that you evaluate your interventions. Provide training, support for managers, but also give them time to, you know, to perform this important task. Raise awareness of the support and make sure that everybody can access it. Ensure active participation and commitment by everybody in the organization. And also, you know, managing burnout is not a task and finish process at all. It's going to be a continuous process of measurement and intervention and evaluation. So moving on now, thank you very much.
Thank you very much indeed, Gail. That was a great sort of overview of the whole thing, and nicely left with some solutions, and not just telling us how horrible the situation is. I think if we could go on to the slide with the panel information on it. So what we're going to do now is to have a panel discussion. I'm going to very briefly introduce the people talking on these particular questions. You can see the questions are the ones in italics. We've only got 5 minutes per question, so I'm going to ask the presenters, the discussants, to stick to 5 minutes, and I will come back on with my microphone and cut you off at the 5 minutes, because otherwise you won't have any time for questions. So please do stick to that 5 minutes. That would be great. So the first question, which is, what is the role of occupational health practitioners in preventing and managing burnout? So Professor Anne Harris, as you probably know, is an occupational health nurse and a past president of the Society of Occupational Medicine. And Janet O'Neill is a general nurse, but she's a clinical nurse director and deputy director of the National School of Occupational Health. So I'm not sure how you're going to split it. And Janet, you have 5 minutes.
Thank you. Okay, well, I'm going to start by talking about proactive approaches to prevention, talk a little bit about supporting a client, and then bring in Janet for further comments. I very much feel that managers are key to preventing burnout, that they have to understand what causes burnout, what they can do to prevent burnout, and how they can support members of staff who may sadly have ended up burnt out. So as I say, for my 2 penneth, education is absolutely key, particularly in relation to organisational risk factors. And this is quite nicely elaborated on page 15 of the document we've been looking at. I think it's really important that managers understand the factors in the workplace that can negatively impact on the mental health and well-being of their staff. A good starting point, from my perspective, is thinking about the health and safety executive management standards. So does the manager really understand the job demands of the staff they employ? And I mean really understand. Have they spoken to them about the job demands? Do they appreciate how those could be negatively impacting on the mental health and well-being of those staff members? How much control do the staff members have in relation to the tasks that they carry out? What about working relationships? I put something in the chat earlier, and perhaps Nick, you can add the link, please, about an earlier document produced by Gail et al. On the mental health and well-being of nurses and midwives. And within that document, bullying came out loud and clear, which is absolutely awful to think that this is going on in healthcare settings amongst healthcare practitioners. So what are those relationships like? Is there evidence of perhaps bullying or being unpleasant in the workplace? And if that is the case, what can be done to nip it in the bud? What about the person's job role? What about how the organisation manages change? Thinking about the supports that is given to staff members, and it might be from the manager themselves, peers, or employee assistance programs that the organisation have put in place. What's the culture of the organisation like? And that comes from the very top. Thinking about whether the manager understands possible signs and symptoms of burnout. So OH professionals are key to educating managers about all of these things. Does the organisation support compassionate leadership? Thinking about now an employee who may well be suffering from burnout, considering how they can be supported in the workplace. And obviously that has to be very much related to the particular individual. So it's not one size fits all. And that
2 minutes left, Dan, between you
right,
and Janet.
I'm going to pass on now to Janet if she'd like to add anything.
Okay, thank you very much for that. And I think that's been all encompassing. But I think the role of occupational health is really understanding that organization. You know, we understand the impact of health on that individual, but also the impact of work on that individual, and getting to understand that workplace is absolutely key. So supporting that organization to do that sort of management standards, stress risk assessment for us to analyze the outcome from that, and to help organizations to put into place plans to support and reduce that, you know, any risk of burnout. But certainly educating managers, and mentioned, is essential. And we in occupational health are key to being able to support that education of managers. But we also assess individuals, and we're able to provide that supportive plan for that individual, but also for the manager on how to manage that individual from the perspective of burnout, and providing that individual with the support or signposting that they need. So certainly occupational health has a massive role. And I see somebody put in the chat about managing fatigue. And that is when we do a workplace needs assessment, we look at all of the different aspects of that particular workplace and culture. So the shifts, the long working hours, and those particular aspects. But my very last point is around the data that occupational health can pull out. That data can really help to inform that organization and keep it as, you know, as a rolling process, as opposed to just a one-off assessment of their workforce, which I think is absolutely key. It needs to be an ongoing process. And that's it.
Thank you very much. Thank you, Janet. Thank you, Anne. That's absolutely great. The next question is, how can we manage burnout in healthcare among people who are neurodiverse? And Dr. Nina Parson, who is a chartered occupational psychologist, is going to talk. And importantly, she was the co-chair of the British Psychological Society Division of Occupational Psychology Neurodiversity at Work Committee. So, Nina, thank you. Perhaps I'm going to check that Nina is here.
Yes, hello. Hi,
oh, great. Thanks, Nina. Hi. 5 minutes. Thank you very much.
So I think the key thing to consider is that if an individual is neurodiverse, the impact already is compounded in many ways. Generally within a work environment, we see across the board in different industries that there are already currently challenges that they face day to day. And then coming into the healthcare sector, that is obviously compounded by the types of challenges that environment puts on an individual, as has already been discussed today, that Gail very kindly mentioned in her presentation. So you're already starting from a point of where you have people who are already kind of trying to manage day to day as it is. And then with the extra stress and pressure applied in the healthcare sector, as has been illustrated, that just compounds the impact of that. So how does that play out? Well, what can we do then to manage that burnout, to ensure that we can try and somehow lessen the impact? I think some of the key things, as Anne has already mentioned, is to do with the organisation culture, and it's about line manager awareness, absolutely. But it's also about kind of recognising who is at risk. And if someone already has a diagnosis, and if they feel that the culture is such that they can disclose that, that puts you in a much stronger position to be able to recognise that individual may be at a greater risk of burnout, perhaps, than would otherwise have been recognised. It's also emphasising a culture where help-seeking behaviour is okay, and that there are support mechanisms in place. So you've got that side of the organisation, and things that, as have already been talked about, like the wellness action plan, having that in place from the outset, or having the individual know that they can self-advocate, because often that is another key aspect. If the individual is able to talk about what their challenges are, you've got an ability to understand that individual from a much earlier stage in the process, and therefore be able to identify and support that individual sooner. And I think one of the key things to take away in the healthcare sector particularly are, in terms of neurodivergent individuals, is that often they have sensory overwhelm, and it's about managing energy levels. As I said, day to day, just getting through the day can often be very challenging for neurodivergent individuals. So then applied in a situation where that they're under greater amounts of pressure, and that feeling of needing to be the white knight puts extra burden upon them. So it's understanding what can we do in that kind of environment to support them. And some of the ideas that you might want to consider are things like having sensory breaks, for example, recognizing that they need to perhaps unmask occasionally, because often they come to work and being a particular person and a professional person, but that takes a lot of time and effort and energy. So by the time they come home, they're completely depleted and have no energy left for day-to-day tasks, then go back to work the next day and repeat that again and again and again. And the impact over time is obviously going to be potentially very risky to that individual's health. So things that we can do are, for example, setting clear boundaries, perhaps looking at the way that their day is broken up. Are there ways that we can perhaps manage their day better? So if they have high concentration levels in the morning, to do more kind of important sort of tasks that involve quite a lot of concentration, such as writing reports, and then in the day, and then do other types of tasks later on in the day. Is there an opportunity to break away, have short breaks, because often sensory overwhelm, whether it's working in a busy ward, being surrounded
just
by
say what 1 minute left, Lena.
Okay, so these are just some of the areas where we can perhaps look at how we can support that individual by giving them the space to work effectively, but also take account of any sort of sensory challenges that they may face in those sorts of environments, as well as being very aware of energy levels as well.
Great, thank you ever so much. That was very, very helpful. The next question is, what is the role of psychological therapies in treating burnout? And I'm pleased to say that we have Alan Dovey to speak on that. He's a lead consultant psychotherapist and has a specialist interest in burnout, and he's the clinical director of Working Minds UK. So Alan, 5 minutes for you, please. Just check the participants. It doesn't look like Alan is here.
No, I can't see him.
Okay, we'll miss that one out, but I can tell you there is a role for sure. But perhaps we can cover that in some of the questions. Then we'll go to the last question, which is what are the priorities for future research and practice? And that's Gail again, but also Kevin. And just to say, Dr. Kevin Teoh is a chartered psychologist. He's the program director of the MSc in organizational psychology at Birkbeck. And he has lots of research roles relating to healthier workplaces and also about making things happen, translating research into practice. So you have 5 minutes, Kevin and Gail, the floor is yours.
Thank you, Neil. So I've got 5 points I was going to share, really, and I'll try and do it in the 5 minutes. And the first one is, I think, from Gail's really thorough presentation, we heard about actually taking a more systemic approach in approaching and managing burnout. And what we have is principles, we have examples, we have recommendations that come from the report today, but also other reports and case studies from earlier on. But I think the challenge sometimes comes with how do we actually create organizational type interventions. It's a lot easier to focus on the individual, but actually when we want to talk about creating systemic change, that can be a lot more difficult. A lot of the learnings that we have come from best practice, from case studies that have worked, but actually what do we know about places that have tried to do something and actually things haven't gone to plan. So I think there's a lot of potential for learning to do in those environments. And similarly as well, when we talk about organizational and group-based interventions, these often take time. They can sometimes require resources as well. And the challenge then is if we have groups of people who are struggling right now, what can we do right now to try and support these individuals or these groups of people? And that, I think, is a challenge for both research and practice. And picking up, I think, on one of the comments in the chat earlier on as well, the whole thing is about how do we manage different stakeholder groups? Because again, when we talk about burnout being an organizational, being a systemic issue, you know, what can OH do, occupational health do, to influence the leadership and the management of how an organization, how a trust, how a department, or even how the whole NHS is being run? And within that, how do we work across different stakeholder groups? And that could be occupational health, that can be HR, that can be the board of directors, different occupational groups as well. So that is something as well to consider. The third point is around recognizing the diversity within our workforce. We talk about the NHS workforce being, well, that's what we refer to it, and the assumption then it's quite a homogeneous workforce, but actually it's not. We also know that the experiences of different groups of people is really varied. We've heard a little bit more about neurodiversity today, and of course the questions being raised and asked around ethnicity, about gender in the workplace as well, but also research has typically primarily focused on doctors and the nurses. Gail mentioned that a little bit more on midwives, but there are lots of other occupational groups that's really underrepresented in terms of who we're working with, and that is something else that we, both in terms of research and practice, need to explore in a lot more depth. And then the final point actually is around how do we evaluate and share interventions and best practice. I think the thing is not that things aren't being done, but I think sometimes things are being done at a more local level. But how do we evaluate? How do we know that what we're doing is working? How do we, in an environment which is strapped for resources, demonstrate that actually there's a return on investment, that we should be carrying on doing what we're doing, or perhaps we should actually abandon what we're doing because it doesn't appear to be working? And then how do we share this best practice? How do we shout from the rooftops when things are working? The challenge has always been, we've talked about academic journal publications, but that only caters for a certain audience. But how do we reflect and learn from each other? So those are the few points that I wanted to pick out on. Gail, is there anything that you wanted to add on that?
Gail, anything from you on that one?
Sorry, just trying to unmute. I couldn't for a moment. Thanks very much, Kevin. I think you've picked up most of the things I did want to say, particularly the sharing of best practice, because the naming and the shaming is important, obviously, but you know, we do need to identify and share best practice, hugely important. And again, I just wanted to emphasize again the importance of using evidence-informed interventions, because there are still those around, there's very many around that aren't necessarily based on evidence. And I think, you know, we did our best in the guide to try to pinpoint those that are, you know, just to show a few examples, I think. But, you know, other than that, I think that's absolutely fine.
Great. Well, thank you very much indeed for all those discussions. If I could ask the panel basically to, when I'll take out some questions and reflect them to you, and I might put them to one of you, but if anyone else on the panel has an answer as well, please feel free to unmute and just sort of chip in so that you can give your point of view. One of the first questions that came in was from Maggie, which was, at what point does burnout become classified as depression, as many of the features are the same? I'll just take Chair's prerogative to say a little quick bit about that, given the fact that Alan wasn't able to join us. I think the key thing about psychological therapies is that if one was treating depression, there's a whole range of nice approved evidence-based approaches to treat depression. But if the cause of the depression was the underlying burnout, then actually there's no point if you don't address the organizational factors, because otherwise the depression won't get better, because the thing that's causing it is still happening. So I think the key importance about recognizing burnout as a cause is not to just get on and treat whatever the mental disorder is with psychotherapy. You have to also address the organizational issues. So does any of the panel want to comment? I mean, maybe Gail or Kevin, I don't know, on at what point does burnout become depression? If you don't want to comment, that's okay. Or was anyone else, any of the other panel members? No, okay. I think from my point of view, and as a clinician, as a psychiatrist, I would say that the answer there is that I would think of burnout as being a vulnerability factor for depression. Yes, many of the features are the same, but people who are burnt out are still functioning. They're not functioning ideally, clearly, but they are functioning. Whereas when they begin to stop functioning, that's when it will be moving into a diagnostic category such as depression, although other categories like adjustment disorder might also apply. So I would look at as function is the key element, and you could probably see in many cases the sort of burnout become more and more severe until then it starts to flood over into the rest of someone's life, not just their work environment. The next one is really a comment about the mental health hubs. Those of you who work with the NHS will know that the NHS England funded these hubs. There were a number of them, I think there were up to 40 around the country, to provide mental health support to NHS staff. Unfortunately, the funding for that ended in end of March, and there was it was left to integrated care boards and systems to provide things locally, but with no additional funds. So I agree completely that is unfortunate at the moment. And there's a comment here about poor psychological safety. Does any of the discussants have any views on the concept of psychological safety and burnout and how the two interact?
Well, I think the point I made in terms of assessing the psychosocial safety climate is important too. You know, which can be the first step in ensuring that perhaps what organizations think they put in place and what employees think about it, you know, as to whether it's appropriate or enough, can be helpful.
So how would an organization go about fostering psychological safety? What would they do to try and create it?
I think it's all very much to do with the levels of the interventions that we talked about, and unfortunately, and I know there's been a lot spoken about this. There can be quite a lot of rhetoric around, you know, we care for your well-being. We also need to be very careful that the only thing that people put in place are not individual focused interventions, because they are unlikely to improve the psychosocial safety climate. Kevin, do you have any
Yeah, just to add into that, I think psychological safety is paramount, really, because actually often we talk about organizational interventions, we do need our colleagues, our staff to be involved as part of the process in terms of identifying what are issues, what are challenges that people are facing. And if people don't feel psychologically safe to raise issues, then that's going to be problematic, because if you try and run any form of intervention, then it's going to be very much top down or externally driven without really understanding what the local context is. In terms of Neil's question as to how do you develop a psychologically safe environment, that can be quite challenging to start off with if people feel particularly threatened. But I think to start off with, it comes with role modeling. So it's key stakeholders within that environment saying, look, we're going to demonstrate the ability to ask questions, to acknowledge making mistakes, to ask for feedback, and actually to act on that. And I think these are some of the key factors or the key points which I would encourage people to start thinking about. So what information are you collecting? How are you responding to that? So it's a case of saying, look, whether it's surveys, whether it's focus groups, what are you hearing and how are you responding to that? I think sometimes people misunderstand and say, look, we've got to fix and address everything, and therefore we're afraid to ask. But sometimes it's about having that communication back to our staff groups to say, look, you said this is going to be possible, this is not going to be possible because of what? And I think by initiating that dialogue, making sure that people are heard and people know why they are feeding into the process and what the information is going to be used for, I think that's quite important to start the process.
Absolutely. Can I just add something very quick there? One of the most important things also is to disseminate the findings of surveys and research openly and honestly. People will respect you a heck of a lot more if you stand up and just, talk about the bad stuff as well as the good stuff.
Absolutely. Reflects on, we did a big study looking about organizations and stigma and how you create a better workplace. And there's different approaches, but one of the approaches is called protest. And what protest is that when something goes wrong, rather than sort of covering it up and moving on quickly, is to actually hold up the bad thing and to say, this is not who we are. That might have been us 20 years ago or 10 years ago, and we accept these things are wrong, but that is not who we are now. And to publicly talk about that. You might remember some years ago, there was an outcry because Asda bought out a Mad Axeman sort of costume that you could buy around Halloween time, but it was the Mad Axeman, that somehow that the Axeman who was killing people had to have a mental health problem. And there was a Twitter storm about it, and Asda took it off the shelves and said, that is not what we meant. But actually, sometimes making a song and a dance about bad things, because things are always going to go wrong, is actually not a bad thing to do. And next one is, I think Anne or Janet, I don't know if you want to comment on this, is about healthy worker effect. Is can an organization create a healthy worker through the healthy worker effect?
Well, that's a very interesting question, because we can do what we can to try and promote a healthful working environment, but it doesn't necessarily result in very healthy workers. One of my bugbears is when organizations realize there's a problem with stress, perhaps, and they say, well, we'll have mindfulness classes available at lunchtime, Pilates, we'll have a bit of fresh fruit on Friday, and think that everything will be fine the following Monday, particularly when they instigate resilience training, which to me is very victim blaming. We should have resilient organizations, not expect our employees to go to a course and then be better the following week. I'll pass on to Janet. Would you like to add to that, Janet?
Well, I'm going to actually refer back to this excellent report, which talks about, enhancing self-appreciation, being more mindful, and promoting emotional literacy, because all of those elements are the elements that are going to help people to have that sort of a healthy worker effect. So without those, you're not likely to get somebody who's going to be focusing on their own general health and well-being. So I feel those are really good, strong starting points for a healthy worker effect. But actually, I wanted to skip the conversation right the way back to that depression question earlier, if that's okay.
Yeah, absolutely.
And that's because, as occupational health advisors, we assess individuals. So an individual might come into us for one thing. So, for example, depression, which is a really common reason for people to be referred into occupational health. But then we identify that burnout is actually, behind those symptoms. So managers themselves may not recognize that, but we would recognize that, and then be able to reflect that back to management, back to that individual. So we as a profession can be extremely helpful for identifying that actually, the person might be perceived as depression, but actually burnout is the issue then.
Thanks very much indeed, Janet. That's a very useful point. The next question is about work-life balance, but I might ask Nina, I'll ask you to comment on this from a neurodiversity point of view. Those of you who are listening may well know that SOM also has a neurodiversity guide which came out, which is I think really useful for workplaces generally. So Nina, from a sort of neurodiversity viewpoint, given it's a pretty common condition, what's your view about maintaining work-life balance?
Yeah, absolutely. I think, work-life balance for all of us is absolutely key. And I think it's setting those boundaries. And often if you're neurodivergent, having that scaffold, having that boundaries that you're working within can enable you to feel more sort of in control of your work life and life together. So I think that's one of the key things. And it's for the organisation to recognise that there may be a requirement to adapt the working practices of that individual to enable them to thrive at work through having an adaptation to their work and life balance, so that they're not feeling that they're totally overwhelmed. Like I mentioned earlier about going home at the end of the night, you completely spent all your energy at work and there's nothing left in the tank. That's not healthy for anybody. So it's just being aware of what we can do as an organisation to support that individual. And it could even be, as I said, a workplace assessment to look at adjustments for that individual is probably a good place to start to sort of, you have to kind of regulate it and put it into some kind of formalised report so that it can actually be actioned and is taken seriously. And sometimes you have to go to that level in order to get the support in place for that individual. We'd like to think, we talked about the culture of the organisation, and that's again one way that we can look to try and address some of that balance.
Thanks, Nina. One perhaps for Gail or Kevin, just a very quick one, really. What's the difference between fatigue and burnout?
Oh, that's a good question. Can I just add a little bit to what Nina said?
Oh, yeah, of course.
Come back in a minute. I think what was also mentioned about the work-life balance issue in the chat is obviously the move towards home working and hybrid working. And these pose new challenges, for well-being, obviously. And certainly in my experience, many organizations will do risk assessments for ergonomics. Is your computer monitor high enough? Is your chair safe? Do you get up and move around every now and again? But, there really does need to be a psychosocial risk assessment. There is a particular risk for people dealing with emotionally demanding types of things online. I work with child protection social workers who often have to deal with some pretty difficult issues in their own home, so it actually brings with it some new challenges, I think, that we need to consider. Sorry, Neil. Moving on to the fatigue.
Yes.
I think it's certainly, with burnout, it's much more of an emotional fatigue. Obviously, there is physical fatigue as well, which can lead to, physical health problems as well. But the emotional aspect and the impact on levels of feelings of compassion and empathy for other people, I think there's an important difference there. And obviously, fatigue, most people tend to go to bed and wake up in the morning and they feel a bit better. But this is the type of fatigue where people often say that they feel tired in their bones. Is that something that resonates with people? And it isn't something that can actually be, cured by just a good night's sleep and a holiday, let's say. So intervention is certainly needed. I'm not sure if that answers your question, though.
Yeah, and as with most of these sort of mental health matters, sometimes this is about subtleties and professional judgment. But burnout certainly is more than just fatigue. Fatigue might well be part of it. And certainly GPs, those of you who look at GP records, will often, see TAT, they're tired all the time. Is something that sort of GPs recognise as being a common thing. And I think if you hear that as an occupational health professional, or as a healthcare professional, or as a manager, then actually you should be asking some more questions about what's going on at work to find out why they are tired all the time. Perhaps an interesting question, particularly given the current topicality, but does anyone on the panel have any perspectives on the relationship between burnout and the menopause? Has there been any work done? Is there any thoughts on that? Anyone want to jump in?
I'm not sure if there's any work being done on that, but I can see definite overlap between the two. And becoming particularly tired because of menopausal symptoms, perhaps because of poor working conditions, like very hot conditions, not being able to have sufficient breaks, etc., etc. So the menopause might exacerbate the burnout, or the burnout might exacerbate the menopausal symptoms. But that is my personal perspective. I'm waiting for Neil to say, where's your evidence for that? Because that's your particular stance. You've got to have the evidence. That's something that I think should be investigated further.
Yeah, well, I would agree with you. And I mean, it's if there isn't evidence out there, then you have to rely. The lowest form of evidence, of course, is expert opinion. So when you're left in the void of no one knows anything of any detail, then you'll absolutely have to have your expert opinion on that. There's no problems at all. Perhaps one, and it may not necessarily be an easy answer, but it'd be interesting to have anyone's perspectives, is that if demands are recognised as the key element leading to stress at work and ultimately burnout, and resource doesn't grow to meet the demand, what do public organisations do? If you're the senior board of an NHS and organisation and you've got more demands on you, but there's no more resource, what's the answer? Nice simple one. Gail.
I think Kevin will have something to say about this as well. But what I did want to mention is that some interventions can actually be very, very effective, but very cheap, if you like, to implement. But certainly if we look at some of the models that we mentioned in the guide, like the job demands control support model, or the job demands resources model, it suggests that if you allow people more autonomy, or if you support people more, or if you give them more flexibility, that can then help them meet the demands that they have. Although obviously, we really do need to recognise the need for more staff. I'm aware of a recent research actually that talks about job crafting in GPs. And this idea that, if you give GPs more autonomy and control to craft their work, it enables them, to sort of meet the demands made upon them more effectively. So I would encourage you.
Can I ask, what does that mean? What does crafting their work mean?
Crafting is all about choosing and developing your work, if you like, and perhaps sorry, I'm not putting it terribly well here, Kevin.
We often talk about job crafting in the workplace adjustments report, because of that individual that has certain strengths in certain areas and maybe struggling with other parts, is having some autonomy over how they structure their job role to focus on areas where they can they feel that they work at their best, or areas where they have particular expertise and doesn't have the same level of demands or energy depletion as perhaps other parts of their job role. I think it's slightly different to perhaps the way that Gail was defining it, but that's just from a kind of a generalised sort of workplace adjustments assessment perspective.
Okay, that's actually useful to know. So I guess taking that together, that sounds like that actually, if you're particularly good or you particularly enjoy some things, maybe you should do more of that and let someone else, hoping that in the team you've got people to cover all the different tasks that need to be done. Well, listen, it's I was going to
come in very quickly.
Oh yeah, please, Kevin. Yeah, please.
Yes. Just in terms of what Gail was saying with really in public sector, ideally you want to reduce demands and increase resources. The challenge always is it's not going to be possible. And actually in relation to that comment, earlier this year, we worked on a Welcome funded project in the NHS where we were looking for organizational type interventions where people have tried to reduce demands and increase resources. I can put a link in the chat where we've got case studies where people have said, this is what we tried to do with some success. And it goes back to the igloo model that Gail talked about. Really what we want is to encourage people to recognize that whether it's at the group level, the leader level, the organizational level, there are things that potentially can be done. It's not going to be a silver bullet. You're not going to solve everything, but there can be something done at what level you are. But equally, the final O, which is the overarching context, and that's government, its stakeholders, its national policies, it's recognizing that we need to collect the evidence to inform that discussion, to push for change, to lobby, and whatever that is, to increase resources and reduce demands at that level as well.
Great. Okay. Well, thank you very much, Neil. Thank you for all the discussants. I think they've been really useful. And as you can see, there's lots of questions. I think we didn't get through all of them, but we got through most of them. So hopefully you'll forgive me for not getting through to the last one or two. For those of you who haven't found the link, you'll see in the chat also there's actually the link to the guide itself, and also the guide on neurodiversity as well, if you want that in the chat. Thank you ever so much for Som for hosting this. Thanks for Gail and the team for putting together, what I hope is going to be a really useful and importantly well-used guide for healthcare organisations. But as Gail said, there's plenty in there that other organisations can actually use as well. And certainly, I think from my reflection is I talk to a lot of NHS and healthcare organisations about mental health and mental well-being and the like. And one of the slightly concerning bits of information that I hear repeatedly is that many staff feel that they're being told to be more resilient. That it's and so resilience is becoming, to quote Blackadder, a bit of a dirty word, because a staff member is just meant to get on with it and be tougher. And as Gail said, and Anne as well, just giving them a mindfulness course, or just giving them a resilience building intervention by itself is not going to be the right answer. So I think we very much need to do whatever we can to talk about resilient organizations and resilient teams. And resilient teams, have that characteristic where the supervisor sometimes will say no because they'll be protecting their staff, even though that might not be something that their managers want to hear. But no is also not a dirty word. And the other thing is that as much as you can to create we've got each other's back. And I think if you can get to that point where actually in a team, you don't talk about you and I, you talk about we, what we do together. That I think leads the team in a much better place to be resistant to burnout, because we are not going to let us get to the point of being burnt out. So thanks very much for listening and for staying to the end. Please download the guidance and document, and I hope you have a very restful and not at all burning out afternoon. Thank you very much for your time. Bye-bye.
And thanks very much to Neil for chairing so well. Excellent.
Right.